26 يعني الدوز كالكوليتر. الدوز كالكوليتر شوي مبين يعني different data.
Welcome on board our dedicated attendees. Good evening, everyone. This is our first session of health informatics with our great and dedicated speaker, Dr. Sajid Abdo. Health informatics is a growing multidisciplinary field that combines research methods and applications of technology to improve healthcare systems and outcomes. Welcome on board, Dr. Sajida. Dr. Sajid Abdo is a senior pharmacy informatist at King Faisal Specialist Hospital and Research Center in Riyadh, KSA. At her role, she works with the clinical and operational experts to design and deploy effective value-driven informatics solutions and pipelines for streamlining pharmacy operations, improving patient safety and enhancing patient and staff experience. Prior to her current role, Dr. Abdo worked in the United States as a pharmacist and pharmacy manager at CVS and community pharmacies. She also established and managed Central Care Pharmacy in Minnesota that was later acquired by CVS Health. She also co-authored multiple studies in Purdue University and University of Minnesota as a researcher, including the e-prescribing guidelines for the Minnesota Department of Health. Dr. Abdo has 15 plus years of clinical and informatics experience. She's an American board certified pharmacist and medication therapy management provider. She holds master's degree in biomedical informatics from the University of Minnesota and bachelor's degree in pharmacy from the University of Jordan. Welcome, Dr. Abdo. The stage is yours.
شكرا دكتور صبرين يعطيكم العافية. Thank you everyone for attending this session. Inshallah will be enjoyable for everyone, experts and people who are away from oncology. And inshallah we'll make it as smooth as possible. And first thank for Dr. Samat Abara for inviting me to this beautiful initiative and establishment of IVPN. We're all proud of this. I'm gonna just recap what Dr. Sabreen has mentioned. My name is Sajid Abdo, pharmacist, worked CVS Pharmacy for a few years, graduated, of course, from the University of Jordan with a bachelor's degree in pharmacy. Then moved to the States to work as a visiting scholar at Purdue University. Afterwards, we moved to Minnesota, where I worked as a researcher and resumed my studies in biomedical health informatics. I worked alongside at CVS Pharmacy as a registered pharmacist. And then I decided to establish my own pharmacy. It was the first Arabic-speaking pharmacy in the state of Minnesota, of course. And then it was later acquired by CVS again and worked with them until I landed at KFSH Hospital, our beautiful organization, highly reputable, alhamdulillah. So this is just a quick intro about myself. For our meeting today, inshallah, we're discussing oncology module, everything that's related to the oncology patient care. How did we move up the ladder within KFSH Hospital? How did we acquire a new module? What areas of strength we have? What other challenges and opportunities for enhancement would have for the future? So please feel free to interrupt me any time. I would like to have this as much interactive as possible. I'll make it kind of in between, not too hard, not too specific. And at the same time, if we have any specialized people, they would see the sophistications we've been building and doing through the module. First, a quick introduction about our hospital. We have 3 organizations, 3 facilities, 2 in Riyadh, the capital. We have CCC, the Children Cancer Center, and then we have the original, or the facility in Riyadh. We have 1 in Medina and 1 in Jeddah. This is a brief about the establishment. Of course, KFSH was established 1975. We have, I know for sure it's above 2,000 beds for now. I think these numbers from 2018, but we exceeded 2,200 beds for total facilities. We have almost around 60,000 operation hours. We have, we're distinguished with transplants, number of transplants we do, either heart, kidneys, lungs, liver, so on and so forth. We have few thousand. I think the number is all even higher than this, with 70 plus nationalities from around the world. KFSH achievements, we've of course gained along the years. Many awards, alhamdulillah, with the effort of the management and the employees working side by side. Recently, from HIMSS, we got HIMSS Imran, Amam for Riyadh and Jeddah. Of course, we're accredited by GCI. So, alhamdulillah, we're online with the world best practices. In terms of oncology, if you want to just highlight a few achievements, the most recent one was King Hussein Award for Cancer Research. It was handed by Queen Rania to Dr. Majid Al-Fayyad and Dr. Mahmoud Al-Jurf for clinical research for oncology research or cancer research. Of course, the Cancer Center at KFSH is accredited by the World Health Organization. KFSH in general is ranked 76th among the top 100 healthcare institutions. And it was recently ranked the first in the Middle East and Africa in terms of brand finances. Few centers of excellence in KFSH, where KFSH is very well known worldwide for. The Heart Center, organ transplant, again, with leaders in cardiac or heart transplant, adult oncology, neuroscience, pediatric hematology and oncology, and medical genetics. In specific, we're diving into the cancer care. Our oncology center covers the research unit, adult hematology, HS, CT, palliative care, radiation oncology, and medical oncology. The center has implemented recently CAR T cell therapy, which is state of the art for cancer treatment. And KFSH has successfully treated 20 patients, which 14 of them are adults and 6 of them are pediatric patients. We saved approximately 70 admission days with the use of electronic smart ambulatory infusion pumps, and many other achievements for the Cancer Center. We have probably around 90,000 radiotherapy sessions done so far at King Faisal. Again, huge numbers for huge facilities such as. Diving a bit more into cancer statistics, we all know that the statistics in 2022 was estimated statistics. The last accurate statistics was back in 2019, just due to the pandemic and the discrepancy of data we could gather. The estimated number in 2020 was 1.9 million, almost 2 million cases, which 500,000 of them will unfortunately end in death. Although cancer is the second leading cause of death in the United States, Good news is the number of people surviving cancer is, alhamdulillah, dramatically increasing. People surviving, not dying from cancer. Of course, speaking of technology and health informatics, we would give some credit for technology, which has helped immensely in the fight against cancer. But even with these advancing technology, you still might see major gaps that exist in oncology patient care. We're gonna speak about transition from paper MAR to electronic MAR. So first, we wanna point out the disadvantages of having probably the most dominant solution or approach, which is having paper MAR. MAR is medical records for patients, usually saved as on paper and files. These kind of gaps, of course, we do see kind of staff frustration. We do have piles of paperwork that we have to shove through. We're going to talk about research, storage, security in the next slide. So here we do have increased the risk of misinterpretation when we do have a paper copy of the protocols ordered for a patient. There is a huge chance of misinterpretation of the data and transcribing these orders into the system, and the lack of computerized alerts and reminders in case there is any mistake or a missed opportunity for the provider. Second gap is inefficiency. Inefficiency is usually due to the lack of resources and access to patients' lab and clinical notes, which would result in communication gaps. And then ultimately, as we all know, that would negatively impact patient care and quality of care, of course. Paper records can be, speaking of limited security, can be destroyed very easily, probably impossible or irreversible destruction. And it's very hard to recover if the disaster is a physical disaster or probably malicious activities such as theft or data breach. And as we know, like what is lost for good. So this is a huge disadvantage. Access history is one of the disadvantages here. Research data limitation. Of course, when you have piles and piles of papers, it becomes much harder to gather this information and for data management. And it's so hard to track the trends in research and treatment. Last but not least, we have storage limitations, let alone wasting ink and paper. Storage limitation is a big concern for every facility. And wherever I went, wherever I worked, storage of paperwork and patient data, so we don't violate HIPAA, is always a concern, probably a nightmare in some cases, because that will end up with additional cost on the facility. Probably to rent additional rooms or spaces to store these data. Any questions so far? Probably I want to. Yeah.
There is one question about the voice. Is the voice good? You can write in chat. There is one question from Muhsin Wani. Can you also brief about the rise of cancer in growing children? Maybe this is not the scope of our session, but if you have a short answer, we can.
Well, unfortunately, I don't. I know the cure rate is increasing in children, especially the most common type of cancers, leukemia and lymphoma. The cure rate is dramatically increasing, which is good news. Other than that, I focused on this module on adult oncology. but I can get you the information if you're interested.
Thank you.
Dr. Sabrina, I just wanted to highlight access history. This is pretty kind of interesting nowadays, since this access on the paperwork, as you see, we cannot put a lock on the paper more. So we don't really know who read and had access on the information we have, especially if we're talking about high-profile people or celebrities, for example. We usually add additional locks on such profiles and such charts. While on the paper file, it's kind of hard to do that. Access is not monitored. Even if we know there's a data breach, we don't know who is really the actual person who did that. So these are summaries for the challenges we have with the paper more.
Yeah.
And here comes, do you have any question?
No, thank you. You can continue now.
Thank you. So here comes the urgency and the need to switch from paper MAR to electronic records. This is very crucial since after we had to deal with all these gaps over years and years, King Faisal determined the absolute need to switch from paper to electronic. And it's Takhasusi Hospital, when we are exploring EHR options, especially for the oncology module, we were looking for a patient-centric integrated workflow that can leverage our current and existing Cerner EHR investment. We already have Cerner. We don't want to segregate the work. We wanted something seamlessly integrated into the system. And that would certainly optimize care coordination and improve patient safety. So the committee, we have several committees that we're engaged in the decision-making from the point of acquisition till the point of after go live and after implementation. Of course, we have committees from the health informatics, since this is an electronic system, alhamdulillah, guided by Dr. Osama and many other Ustaz Fahad, Ustaz Mu'tasam, Dr. Abdullah Turki, many others. I don't want to miss any names, but we have a great committee to steer such decisions. We always have project administrations, clinical advisory group. We have the medication task force. Technically, everyone who can make a decision and who can be impacted by the decision. Any stakeholder would have an impact. And of course, for every category, we do have a representation from different service. Now, as we are exploring the EHR, we need to know what providers and clinicians, pharmacists, nurses, everyone who's interested, what they're looking to see in that MAR, or what does the MAR include, or the patient chart include. Of course, we need to include vital signs, temperature, measurements, lab values, history of medication, or this is probably indicating medication allergies, previous surgeries or admission history. If the patient has ever been transferred from another hospital, X-rays and imaging, administration of medications like probably high alert medications, history of chronic medications, and so on and so forth. So when we come, now we decided on the module, we decided to go with Cerner. What is it?
I have a question, Dr. Sajida, if you don't mind. No, you can go to the next one, yeah. When we are saying an oncology module or any oncology module related to health informatics or pharmacy informatics, this comes into mind the clinical decision support system. Is it the same? What's the difference, or what's the connection between clinical decision support systems and modules we make in any HIS system like Cerner, EPIC, or any other?
Of course, when you have to adopt an HR system, one of the major components of an HR system is a system to support clinical decisions, either as alerts, as references. Usually it's by alerts. So MCDS, DRCs, MCDS is medication clinical decision support, DRC is those rate checking, and many other alerts or system that can help the physician give better care and accurate care for the patient. It is one component from the bigger picture of HR systems. So it kind of support the physician as he goes, just in case he missed something, he overlooked any aspect during the care, the system will cover that up. So it's a component of MCDS is a component, one component of the HSM, but it's a very important component though.
Thank you.
So for oncology module automation, since we decided on Cyanide, what is the process? As we're looking at it from the IT side or from the health informatics side. As health informatics, although I'm a pharmacist, I know what I'm doing. I understand medications. However, when it comes to oncology, there's very specific processes. So we always have to sit with end users, kind of listen to them. What are your needs? What are you looking for? What challenges you currently have, so we can make sure to cover it during the automation process. So first thing first, we need to sit with the end user, hear their problems, and go from there. Just kind of monitor the workflow, the processes, everything. We take notes, and then we have to match it with the policies and guidelines, which comes next. There shouldn't be any conflict. Whatever policies is dictating, the current process has to follow. We cannot have any discrepancy in between. After guidelines, we need to reach a workflow consensus. And this is one of the strengths that we implemented at KFSH. We have one unified workflow across all facilities. This is very helpful when a provider, for example, is visiting or moving from a different facility. Him or her transition should be as smooth as possible. He shouldn't have any surprises. He shouldn't be considered for retraining just because he moved from Jeddah to Riyadh. We're all under KFSH umbrella. So his transition, as I said, should be very smooth, seamless. What applies to Jeddah applies to Riyadh and vice versa. And in case, inshallah, we decided to expand to new facility, this is very easy replicable. We can replicate the same workflow to other facilities and even to other hospitals. And we had the chance to probably negotiate with other hospitals about acquiring the same workflow that we've adopted, because we invested a lot in it in terms of time, resources, clinical expertise, time, money. So that workflow was really built to the optimum. So it can be replicated easily on other facilities or probably other hospitals. And then we reached the build design. This is our job as health informatics experts. We need to reflect whatever was approved during the clinical validation on the system. Then comes the pre-go live activity. This is just to make sure the integration part is working as expected. The system functionalities Cerner has claimed is working as intended. And that during that phase, we also do the training for both super and end users. And then go the huge milestone in every project, which is the go live. Now the system is up and running. We use it on actual patients. Everyone is happy with it, inshallah, and they can utilize it on a daily basis. Alhamdulillah, our adherence was 100%. Whatever was automated, we have to stick to it. There's no go back to paper charts. So that was a huge achievement in this module and in this project in general. And then after every go live, of course, we have a post go live activity, monitoring and support. Of course, in every project, we might face some probably missed opportunities, system defects, probably chances for improvements. And this is all covered during the monitoring and support phases. Now, we want to discuss like the backbone of the oncology module, the approval of the oncology pre-printed orders or the oncology protocols on paper. Now we have any stakeholder involvement is a must. Clinician, it's their job, their task to keep up with the most updated clinical trials and guidelines. They do sit together to revise and review evidence-based medicine, usually with a specialized clinical pharmacist. We're talking about chemomedication, oncology medications. So we have to have a clinical pharmacist on board, specialized in oncology. And of course, we need to hear from nurses because they're an army on the floor. After they do approve it, they raise it to the oncology committee for discussion and final approval. Now, this committee will meet together. We call it CTS committee, chemotherapeutic subcommittee. We have representation from every facility, again, to unify the practice. And we have oncology panel of experts. They consist of a chairman, oncology physician. They have to be specialized in certain areas. For example, if we're discussing breast cancer, we have to have oncologists specialized in breast cancer. Of course, we have clinical pharmacists, as I said, oncology nurses, and a representative from the health informatics from HITA. This is usually a pharmacist. I do present HITA. This is to guide them through the specific build challenges because we need it to be reflected in the protocol as well. Now goes to the final step, which is the steering committee for approval, formulary and therapeutic committee approval, the formulary governance. This committee approves guideline references. We do have to state references on the pre-printed order on the final approved copy. And they revise FDA approved indication. We cannot give indications unless it is approved by FDA or the hospital formulary. And there is some guidelines if it wasn't approved or generally approved. If it's, for example, offline or general practice, then the provider has to go through any the clinical doses, which is the most important component of an oncology medicine. This is a screenshot of the final, a sample of the final approved protocol. It's very comprehensive. As you've seen, we go through a very comprehensive process for revision and approval. Huge panel, expertise, clinicians with really extensive experience in the domain. So this, we deal with it as gold. It's really precious for us because it's it consume a lot of time, a lot of effort. We gathered a lot of data from different references, and as you've seen, it has one template for all. So it's easier to read as you go. We don't have to change templates in between services. So nurses at the end will look, it's going to be much easier for them to grab the information. It's usually standardized format, not content. And we save it as PDF files in a shared folder, which the access of that folder is authorized only for specific users. This form, what comes to HITA, which is the health informatics team, for build and for reference. Any questions for us so far?
I have one question. If the protocol is updated, you know that science and treatment protocols are changing every day. What our role in this, and how we ensure that the protocols are updated and the guidelines in this module is updated?
Sahih. This is very important, and it is taken into consideration. As I said before, it is the clinician's responsibility to keep up with the latest treatment. So as you see here, we hold regular meetings to revise the old ones and come up with new protocols. Plus, in the meanwhile, until they approve it, we do have the flexibility in the oncology module to probably add and tweak certain medications. If, for example, we had a new pre-medications that's recommended to be added before giving the chemotherapy, then there is some flexibility in the system. So the physician doesn't feel handicapped or like handcuffed, just trying to adhere to whatever was approved. No, he does have the flexibility to change whatever he deemed possible and appropriate for the patient. So although it is a standardized format, but still flexible if the clinical judgment of the provider allows that. And of course, it has to go through the pharmacist for approval and double checking. So we still have some kind of flexibility, and we do the review every now and then. We reviewed and re-edited multiple protocols after it was really built and went live. So yeah, this is very important question we always receive from physicians that they don't want to stick to that specific protocol. What if? So that what if we did open the door for some flexibility, but yet do adhere to the guidelines. So in the build, when it reaches HITA, we do make sure to reflect all the components written in the protocol as automated sections or components. So we include all anti-neoplastic agents. This is very important. It's not only chemotherapeutic agents. We cover everything in terms of chemo, monoclonal antibodies, hormonal therapy, and you can name it. It's not exclusive for chemotherapeutic agents. We do include lab orders at the same time, body measurements that would save a ton of time for the provider upon ordering. We do give them any front end, the vital signs, a view on vital signs, doses and frequency of medications, treatment schedule, what is the spacing in between each cycle, allergies. Again, we're talking about drug allergies or allergic reactions from the treatment itself, from the oncology treatment itself. We have indicators for the nurses, whether or not to go ahead with the treatment. Is the patient fit? Is the patient not fit? Can we defer the treatment for a day or two, or maybe next week until the patient feels better? And we have the supportive medications, either pre-medications or post-chemo medications. For example, nausea, vomiting, diarrhea. We always have to take this into consideration, and it is included, although it's considered a supportive medication. But we would love to have everything from one place, one-stop shopping for everything the patient might need for his treatment. This is a brief cycle of the protocol. Physician has to sign it, plan the treatment according to the best judgment. After, of course, setting the diagnosis and approving the diagnosis from the committee, then it goes to lab to withdraw blood, and they have to chart the results back in the system. Then the nurse comes and check all these labs, check the orders ordered by the physicians. If everything looks good, they send it out to pharmacy, and here by pharmacy, I mean inpatient and outpatient. Inpatient for whatever treatment needs to be given in the hospital, and outpatient, whatever the patient has to take home as a supportive, as I said, for nausea, vomiting, and other adverse effects from the chemo. Then after we're done with this part, times for the infusion center. The patient goes to the infusion center. His chair is pre-booked. Again, the physician does order that ahead of time, and it's all one-stop shop. And we have scheduled time. For example, this protocol would require 3 or 4 hours of treatment, and this chair is under that patient name for that 3 hours or 4 hours treatment. Even if he needs 7 hours or 8 hours, we do accommodate that, even longer time. This is again a recap. Physician do order the medication, nurses take vitals and check labs. Pharmacy, of course, verifies, prepares the high alert medications. Of course, oncology is high alert. We do get imaging, and we can incorporate orders such as MRI, X-rays, and we do send out the scheduling order for booking. And then we have the phlebotomist to withdraw blood and chart lab results as indicated per the protocol. This is a general overview of the regimen. This is a roadmap of the patient journey through this protocol. For example, the patient, the physician elected to choose, for example, this is a breast cancer patient. They elected to choose adjuvant pertuzumab, trastuzumab. Okay, we're going to do it. This is adjuvant. So we have certain number of cycles that the patient has to take. So we do plan it ahead of time with the exact dates. The gapping or the spacing in between cycles are very accurate. Physician doesn't have to calculate anything. It's all preset. And the number of cycles for following up and knowing where the patient is at is preset as well. So it's really all about clicks. And here you can see copy forward. So whatever has been implemented in the previous cycle can be implemented in the next cycle if there is no other changes. That is very helpful in terms like if we remove the medication, like this kind of medication is not needed for this patient. We need to add a pre-medication for that specific patient. We need to do a dose reduction. The patient is not accepting that antineoplastic agent very well. So probably we kind of need to reduce the dose. Whatever has done in the previous cycles can be copied very easily to the next cycles. So it really saves a huge time and thinking and manipulation and probably just copying back and forth, maneuvering back and forth in between cycles by just copying everything that was done, if everything is correct. Now we come to the most important element, the antineoplastic agent. Of course, we can include anything. As you see here, we do include it in two ways. We call it persistent note. This note, no one can modify, no one can play with, so it's standard. And here, the order sentence we call, the order details for the patient, the specific dose and specific route, the infusion time, how would we prepare the medication, how much volume of diluent we need to prepare. Everything, probably clinical pharmacists who are really working on oncology and probably non-oncology would see the nice communication in between the physician and the pharmacist. This order is seen by the physician. It's ordered and signed, and it goes as is to the pharmacist. If you see here, we even set the time. So, for example, the first medication is given over probably 6 minutes or so, and we need some monitoring afterwards. And then the next medication will start at 30 minutes. It's very helpful for nurses just to monitor the sequence of administering the medications. So it helps everyone just be on the same page. Now, this is my favorite part in the oncology module, something we call the dose calculator. We know calculation of dosing, especially with more complex medication, does increase burden on the physician and probably can contribute to fatigue and redundancy. We have this dose calculator tuned to the best. We include every single information the physician might need in order to give the patient the most accurate dose ever. We played with this dose calculator until we optimized it. It supports the most clinical accurate information needed in terms of body measurements and lab indicators. I did include carboplatin because if anyone here ever dealt with carboplatin dosing, we know that it's very complex and can get overwhelming to calculate the accurate dosing for carboplatin. Here, every component is automatically grabbed into the calculator with the dates it was charted. For example, here we have the height, the weight, we have serum creatinine clearance, and it's auto-calculated. No manual intervention is needed whatsoever. We have multiple algorithms here for creatinine clearance calculation. People who know that. We have Cockcroft, and on the other side, we can use either actual body weight, we can use ideal, we can use adjusted, depending on the protocol. Say, for example, here with carboplatin, if body mass index is above 25, then we need to use the adjusted body weight. We did incorporate a value that reflects the adjusted body weight. So imagine you're a physician and you're in the middle of your clinic, or a pharmacist, and you have a pile of work to do, and this dose calculator comes as a saver. It does everything. It does the whole work for you, and been verified and tested so many hundred times, and it proved very successful results. So this is probably one of the backbones of the oncology. Right dosing for the patient is, we can't ask for more. It's the most important thing. If you have it, khalas, you have everything. Next, we come to clinical indicators. This is for nursing for review. We, as seen before.
Sajida?
Yes.
Maybe we have 7 minutes to end.
Okay.
To have 5 minutes for questions. But we have one question from Dr. Nancy Hakouz.
Oh,
Thank you for interesting presentation. How easy was the integration of all of this in the system? Was there any resistance to such integration? Thank you again.
Yes, thank you, Dr. Nancy, for attending. She's one of my idols, Sarah, Dr. Nancy. It wasn't easy, wallah, of course. We did have some resistance, but alhamdulillah, after they started seeing the fruits of that module, they were perfectly fine. Blacks, they started to name it as magic. Everything is one click, and we're good to go. Especially after we've seen the safety has increased, safety indicator has increased, efficiency has increased. Alhamdulillah, the adoption is very well. Alhamdulillah. Going back to indicators, this is for nurses. It's very easy, no thinking. It's either yes, good, meeting the criteria, or no. So no thinking. It's all automated. Again, we can incorporate lab orders as much as we want per the indication. Here we grab all patients' related data. Again, no calculations needed. Everything is auto-calculated for the physician. You just need to look at it and take your decision. Medication history, of course, we have access. Any oncology patient, we need to have full history of his medications, interactions, and so on and so forth. Here, if the physician did miss an opportunity for care, the system would cover him with NCDS or DRC, which we spoke about earlier, Dr. Sabri. Love. So here, connecting the dots, connecting everyone who's taking care of for our, inshallah, this technology will create patient-centered care plans from the point of the initial diagnosis, inshallah, through the survivorship for patients dealing with oncology, with cancer. Here, the outcomes, I did ask nurses about every end user, what are the most important outcomes you got or we gained from this module? First, they said it's huge improvement in the efficiency. We have more clarity since everything is automated. We don't need to probably decipher in handwritten prescriptions, reduce confusion. We did decrease medication errors big time. We have more standardized kind of care. Patient satisfaction is greatly increased. And then we have, again, less waiting time for interpreting the orders. And at the end, we have more time caring for our patients, which the oncology and cancer patients must need. They need to talk, they need to communicate with people, and now we have more time. Challenges, as Dr. Nancy probably asked, we had few challenges during the implementation. We had probably more complex cases that needed more tweaking in the module. We have very patient-specific orders. We have unlimited guidelines. We cannot stop. Alhamdulillah, this is good, but it can become overwhelming with the limited resources we have. Process complexity. You've seen the approval process. It's been very, let's say, very comprehensive, very tedious. We have operation goals, KPIs, needs to meet all of them. We do have change resistance. Every change is faced with resistance. Why do we do that? We're good with the older approach, which is paper. Training and education is ongoing. We cannot stop, and it's one of the main challenges. Future enhancements we have here, we need to expand our services to inpatient and pediatric. Again, we're addressing that, inshallah, in the very near future. We have system enhancements to improve the functionalities, to adopt more kind of patient care aspects. We need to customize those alerts. Sometimes it gets overwhelming to constantly fire alerts to better match the oncology patients and oncology practice. What applies on oncology doesn't necessarily apply on the rest of the services, and the vice versa. And here we need to incorporate other technologies such as digitalization and artificial intelligence. And I really thank you for your time.
Thank you so much, Dr. Sajida. Very imperative and informative session. We have many thanks for your nice presentation. And also we have a question from Sabri. Thanks for the presentation. This module is developed by developers from HIS system or from a team in your center or in your hospital?
Thank you, very nice. It's a combination of both. The original module is by Cerner, but the customization, everything you see as customization is done by our team. It has to be both because you cannot apply one system to all and fits all processes. It has to be customized according to our needs. And if you want to apply it, for example, in King Hussein in Jordan, we have to adopt to their processes and guidelines. So it's a combination of both.
Great. I think we have another question from Muhammad Al-Khuli. How nurses can view the protocol in terms of administration instructions? This is the first question. Also, you have another question. How doses are calculated? Is it automatic calculation? And how is the dose capping? Is it allowed for pharmacists to do it?
Let's go one by one. Comments reviewed by nurses. See this part? This will be viewable for nurses. Of course, the regimen is viewable. The whole regimen is viewable for nurses. So they can read everything the doctor can read. They cannot edit, but they can read. So everything is viewable. Plus, this comment is viewable upon administration in the MAR. So whatever specifications we have, they can read it. Next question, dose calculator.
How doses are calculated? Is it an automatic calculation?
It's absolutely automatic. No manual intervention whatsoever. For every bit of calculation, we had an auto calculation. And it's been tested successfully. No errors, alhamdulillah, so far. Inshallah, will never happen if the provider adheres to the rules of the dose calculator. And for dose capping, yes, for example, here for carboplatin, we do have dose capping. So for example, creatinine clearance is above 125, we do cap it to 125, and that's reflected on the final dose. So pharmacists and clinicians do have the ability to do so. According, of course, to the guideline, because some protocols will not require capping, but some other protocols do require capping. And the same applies to the body surface area. If you want to cap it to 2, you can cap it to 2. If you opt as a physician, if you opt to use the actual body surface area, you can do so. And last question.
Sorry, I was muted. You answered already all the questions. I have one extra question. Do you face overrides on the system for any of the aspects of the module? what's the percentage or acceptable percentage, let's say, for overrides from clinicians?
So it depends from module to module. With oncology, we did recently an enhancement to reduce the override. Just to explain what override means. For example, if we have this is an alert, we call it. So it's either you accept the alert and go modify the order, or you reject the alert. Like, no, I don't accept this recommendation, and I'm gonna go ahead as is. With oncology, we try to reduce it to the minimum because we already have an approved protocol that approves the doses, approved the interaction. Even we try to avoid to put two medications that interact with each other in the same protocol. However, we still have override. The acceptance, it's different from facility to facility. But I would say we don't want to see like more than 30% override rate. The most has to be accepted if it makes sense. But this is a different project. Probably we can talk about it in a different panel. Optimizing alerts is a different world, and it's a really good need in every organization. Alert fatigue is a hot topic. You can discuss it anywhere, and there is plenty of opportunities you can enhance it and reduce the fatigue on providers.
Yeah, great. We have another two questions. Is there a link between PDF protocol and oncology module? I think he means the PDF, the paper or the guideline protocol.
In the oncology module, we are capable of attaching the paper copy or paper نفسها, the copy PDF, to the protocol. Plus, we did indicate if we go to the copy, see this number. This is unique for every protocol. So we do include this number in every build as a note. So the nurse or the physician or the pharmacist can refer to it much easier, even if it wasn't attached to the protocol. Good question.
Another question from Diana Mahmoud. Will artificial intelligence develop the computerized hospital system? What are the possible developments? The role of artificial intelligence in these modules, or you are smiling. It's a good question.
It's a very good question. And this is one of the enhancements we're looking for, inshallah, in the future. Studying the trends for patients. It can go from scheduling to adverse effects and alerts. It's a huge area as well. We haven't dig deep just yet. King Faisal Hospital just established the Artificial Intelligence Center back in 2019. And there's tons of opportunities that we're exploring with this center. One of them is enhancing the oncology. Again, as I said, it can be from patients who do not show for their procedures or for treatment to enhancing patient care and satisfaction, accurate dosing, communication. It can be unlimited.
Yeah.
I'm not an expert in AI, but we will explore. So.
These are great and hot topics in our era. I'm so proud of this presentation, Dr. Sajida. So proud to see health informaticists are rising in our Arab country, in our region. Thank you so much for our attendees. I'm also so glad and proud that we have attendees for this specific title. Thank you all. If you have any questions, you can contact Dr. Sajida, and you can contact me through LinkedIn or through email. I can write my email now in the chat box.
I'm proud to be with you. Thank you so much for the opportunity.
Thank you so much. I can't write here in the chat box, but you can contact me. You can write my name on LinkedIn if you have any extra questions. Thank you all. Thank you so much. Willing to see you in another series of health informatics sessions. Thank you all. Thank you for the IVPN.
Of course. First thing first. Thank you so much.
Good night.